Good evening. My name is Pat Clancy. I'm Vice President for Public Health and Education for the Medical Society of the State of New York, and I would like to welcome each of you to our program tonight entitled ISTOP Implementation. Today's webinar will provide each participant with 1 hour of continuing medical education credits, and will go from 6 to 7:30 p.m. Mr. O'Leary has agreed to extend the questions and answer period for this program. At the end of the program, you will also be asked to complete a CME evaluation of today's speaker. This will be posted at the end of the webinar for each participant to complete on your computer. Your CME certificate will be emailed to each of you within the month. If you are attending the session at a local hospital or county medical society, we ask that a list of participants and emails be provided to us in order for each of the participants to receive their CME certificate. I would also like to welcome Ellis Medicine and Erie County Medical Society to tonight's presentation. You will be muted for the majority of the presentation, and there will be a question and answer period at the end. To ask a question, you can either raise the hand located in the box to the right of the PowerPoint or send us a question via the chat. Please remember to click on your hand after your question has been asked. This will allow us to move through the questions in the allocated time frame. I would like to state that I, Shakira Kramer, or Terrence O'Leary, have no financial interest in any portion of today's program. Today's speaker is Terrence J. O'Leary, and on November 10, 2011, Governor Andrew Cuomo appointed Mr. O'Leary the Director of the Department of Health Bureau of Narcotic Enforcement. As the Director of B&E, Terry is responsible for overseeing the official prescription program, which supplies over 165 million prescriptions forms to practitioners throughout New York State. Terry also supervises B&E prescription monitoring program, which monitors all prescriptions for controlled substances dispensed in New York State. The PMP includes the online substance abuse information database, which provides a portion of this data to a practitioner through the DOH Health Commerce System. In 1998, Terry earned a BA from Loyola University of Maryland, majoring in history, and Terry also attended Seton Hall University School of Law, graduating in 2001. Terry was hired as an assistant district attorney by then New York County District Attorney Robert Morgenthau, where he was assigned to the Office of the Special Narcotics Prosecutor for the City of New York. While serving in OSNP Trial Bureau, Terry prosecuted hundreds of cases ranging from street-level narcotics dealers to mid-level distribution organizations. I'd like to welcome Mr. O'Leary today and ask him to begin the program.
Thank you very much, Pat, and thank you very much to everyone who is attending tonight on this information. So if you go to the next slide. This slide shows you, I want to walk through briefly why legislation was passed in the area of controlled substance prescribing, namely ISTOP. So what this slide shows you is unintentional and accidental death rates in the United States. And since 1973, when the CDC started tracking this information, motor vehicle accidents have always been the leading cause of accidental and unintentional deaths in the United States. That is until 2009, when poisonings, fueled in large part by drug poisoning, drug overdoses, overtook motor vehicle accidents for the first time. And this slide shows you the population rate-based increase of poisonings and drug poisonings. If you go to the next slide, please. This slide shows you that drug overdoses are in large part fueled by the use of opioid analgesics. In fact, the number of overdose deaths attributed to opioid analgesics surpassed 16,000 in 2009 and approached 17,000 in 2010, when it was under 4,000 back in 1998. This is in large part related to the change in opioid prescribing. In 1996, the amount of oxycodone and hydrocodone products ordered by pharmacies and dispensed upon prescriptions increased after being flat from the 1980s through 96, increased over almost 20-fold over the next decade. And as you can see here, the total number of opioid analgesic deaths is more than twice that of cocaine and heroin combined. One thing I'll just say, when we talk about ISTOP, we'll often hear comments such as, it's only going to make people turn to heroin to feed their addiction. One, I would remind everyone on the phone, if you're a practitioner, it is illegal to use your prescribing privileges to maintain someone's addiction under Article 33. And secondly, I don't know that we want our medical profession engaged in the business of feeding people's opioid addiction. You see there was an uptick in 2007, and I would argue, and others do as well, that there was already a turn towards the use of heroin at that point from people who are using opioid analgesics. In fact, one of the last cases I handled in the DA's office was a heroin distribution ring located in New York City, where we recovered almost 1 million dime bags of heroin from a few apartments, and that heroin was actually going to be shipped to Suffolk County, Westchester, suburban New Jersey, very different demographic and geographic areas than had previously abused heroin. If you go to the next slide, please. This slide shows you that the prescription drug epidemic is not only tied to opioids. This data comes from a research letter to the editor written by Len Pelosi and other researchers at the CDC. And what it shows you is that almost 60% of all drug overdose deaths in the United States in 2010 were attributed to pharmaceuticals. While opioids were involved in the majority of the deaths, almost 75%, benzodiazepines were involved in almost 30% of all pharmaceutical overdose deaths. The New York City Department of Health and Mental Hygiene very recently released their own epi-data brief in May of this year, which indicated that almost 50% of all overdose deaths in New York City involve a benzodiazepine. While it's not listed here, stimulants are also a drug of major concern. No drug has a more quickening increased rate of prescribing than amphetamine, which is Adderall, and methylphenidate, Ritalin, also is increasing year over year as well. There was a very troubling study recently released. I'm not sure if it was NIDA or SAMHSA who released it, but what they found was that almost a third of all parents surveyed of school-aged children felt that it would be appropriate to give their child a stimulant if it would, because they believed it would improve their academic performance. And the parents felt it was appropriate to give them that stimulant regardless of whether or not there was a DSM diagnosis for their child. So when you're treating a 4- or 5-year-old patient with stimulants, maybe the patient isn't the concern, but maybe the parent should be. If you Google search how to get Adderall, you will find detailed instructions on how to answer the perfunctory questions which lead up to a DSM diagnosis. So if you go to the next slide, what you'll see here is the summary of ISTOP. The data that I showed you before, which while this was national data, it also presents in New York State's information. In 2004, we had approximately 940 drug overdose deaths. In 2010, that number climbed to over 1,500. In 2011, it climbed from over 1,500 to over 2,000, a 30% increase in overdose deaths in just 1 year. So that in part led to legislation known as ISTOP. And ISTOP was a joint governor and attorney general program bill, and it was voted unanimously by both the Senate and the Assembly. There was not a single dissenting vote to this law, something very unusual for a law which was so vehemently opposed by so many influential stakeholders. So the law is broken into 5 parts. The first is ISTOP, which I will go into and explain later in this presentation. The second part is a shift to electronic prescribing, which you will be hearing much more about after ISTOP's implementation. New York State is shifting its official prescription program to an electronic prescribing program in March of 2015. Part C, we changed some of the controlled substance schedules. One of the things we did was hydrocodone was moved from Schedule 3 to Schedule 2, regardless of whether or not it's a combination product, and everything on the market right now is a combination product. According to the International Narcotics Control Board, the United States consumes 80% of the world's opioid analgesics and 99% of the world's hydrocodone. By moving hydrocodone to Schedule 2, no longer can you write for 5 automatic refills. If you're treating the patient for chronic pain, you can put code D on the front and still prescribe a 90-day supply with 1 prescription. However, hydrocodone, which is the most prescribed drug in the United States and the most prescribed drug, controlled or non-controlled, in New York State, has been moved to Schedule 2. Another drug that we recently scheduled as well is tramadol. Tramadol is now placed on Schedule 4. It is prone to diversion and abuse. It is a drug of concern as viewed by the DEA, and we've now scheduled it. Part D created a work group of which MSSNY was a very active member. This work group worked to issue recommendations on issues concerning continuing education, as well as the implementation of ISTOP, and this work group made recommendations as to accessing and use of the PMP. And finally, the law created a safe disposal program. 96% of all abused medications, opioids, are prescribed in the first instance. This epidemic does not originate in pharmacy robberies or other criminal activity. It starts with people being sent home with a 30-day supply when they will be seeing their doctor post-surgery 5 days later, and they end up using those drugs for a headache, for a separate backache, or another non-medical fashion. And without the proper oversight, many individuals will tend to become addicted. Also, some new literature related to chronic opioid therapy indicates that up to 30% of all people being treated with opioids for more than 6 months may become addicted to those opioids. So if we go to the next slide, please. What ISTOP does is it requires the Department of Health to update New York State's prescription monitoring program. New York State has been collecting PMP data in some fashion since 1973. We litigated the right to collect this information to the United States Supreme Court, and we currently do so over patient objection, over physician objection, and over pharmacy objection. There are 3 separate exceptions to HIPAA, which allow us to collect this information, including an express exception to HIPAA, which states that patient-identifying data may be collected if it's for the purpose of regulating monitoring controlled substances. ISTOP requires that we collect more timely data, and there are proposed regulations which were put into the state register last month, which would have pharmacies report to the Department of Health. Instead of monthly, they would report every 24 hours. And this was a recommendation that was put forth by the ISTOP work group. Finally, ISTOP allows us to share this information with additional appropriate entities. We can now share information with pharmacists. We can share information with local county health departments subject to IRB approval and an MOU between the departments. And we can also allow practitioners to have designees access this information on their behalf, so that while the prescriber will have to consult the information and consider it in making a clinical judgment, they will not be required to actually go to the system and print it out each and every time. Let's go to the next slide, please. The big part of ISTOP is the duty to consult. Starting on August 27th, next month, just over a month from today, practitioners must consult the registry prior to prescribing or dispensing any controlled substance listed in Schedule 2, 3, or 4. In 2012, there were approximately 24.3 million prescriptions for controlled substances dispensed in New York State. 23.4 million. Of those, 22 million were Schedules 2, 3, and 4 controlled substances, so it's the vast majority of the controls that were dispensed in the state. There are certain exceptions, and I will go through those a little bit later, but absent one of those exceptions, you'll have to access your patient's information and consider it when making a clinical decision. If you go to the next slide, please. You'll need to go to the health commerce system. If you're watching, you don't have to write this down in a hurry. If you go to the front page of MSSNY's webpage, mssny.org, they have all of this information and the links there on how to obtain an HCS account for you, how to obtain an HCS account for your unlicensed designees. To help streamline the process, the Department of Health will shortly be rolling out a paperless sign-up procedure for licensed practitioners. We will also be hiring additional staff to take telephone calls and process applications to get rid of the backlog that currently exists. So now if we go to the next slide, what I'm going to attempt to do is actually log into the PMP through the HCS. You will see, I'll go into my account, and what I'm going to do is search patient information. I will tell you, though, that the names I'm using are made up. These are not real patient names. So this is the HCS, and I'm using MSSNY's facility, so there's no shortcut here. This is outside the Department of Health's intranet. So you have to put in your ID, your password, and I understand that your password changes every 90 days, so does mine. Then you have to sign in, and it's taking a couple of seconds to sign in. Once you sign in, this is the first page that you'll see. No longer do you have to sign in and look through the alphabetized menus to find the prescription monitoring program. The cursor right now is over NYSPMP, New York State's Prescription Monitoring Program Registry. If you click on that logo, it will take you to the patient search page. So now if I enter in a patient's name, type in Jack Spratt. Jack Spratt is a male, and so the programmer did make it 1170, which is the default, just so that it doesn't look like I'm cheating. I will put in 1170. And then you have to click, do you attest by the guidelines as specified above? I will go through what those guidelines are. When you click yes, you now confirm that the search is correct, continue, and that's it. That's what an actual search of the PMP encompasses, and that's the time frame as well. We're outside of DOH's firewall, so this is what it takes to do a search. So when you get to the PMP page, what you see is your search term, and if you follow the cursor, I'll be pointing at what I'm describing. The search term, I looked up Jack Spratt, a male, his date of birth, and the search date. This tells you when I did the search. I did it on July 24th at 6:17 p.m. in 10 seconds. So the proposed regulations are going to allow a doctor or prescriber, as opposed to making them check at the time of the prescribing event, they can access the system and review data that is up to 24 hours old. So this report could be used before prescribing to Jack Spratt anytime before 6:17 on July 25th. This report is good for the next day. It tells you who the report was requested by, Terrence J. O'Leary, and it gives you a reference number, which is unique. So the new system has been up since June 12th. And in those 6 weeks, we have had almost 100,000 searches in a month and a half. To put that into frame of reference, the PMP has been available online since January of 2010. In the first 3.5 years, we had just over 350,000 searches. We've done almost a third of that in 6 weeks. We've also more than doubled the number of practitioners who are online. I will say that the calls that we get into my office are one of 3 types. The first call is, why me? Why do I have to do that? Leave me alone. The second call is, I can't get an HCS account, at which point we steer you to the HCS individuals. And the third one is, this is a lot easier than I thought. Thank you very much. And every now and then we'll get reports where people see inconsistencies in the data, and there are multiple reporting tools within the PMP that I'll go through to show you how you can report to us, either by phone or by email. And we try to work with you to correct those. I don't want to pat DOH on the back and say mission is accomplished just yet, because we have additional things to do. But what I will say is a national lobbying organization that represents a specific specialty society had a meeting scheduled with us, and they actually canceled it because they said their membership enjoys using the new PMP and their concerns have been addressed so far. And in my experience, it is very rare that a lobbyist would cancel a scheduled meeting like that. So with that said, and now that I've patted myself on the back for a little bit, I'm going to go through and show you what else the PMP can do. You can collapse the menu if the resolution of your screen is different. Up here, this yellow button will move it over so that you have the PMP on the entire screen. So if we scroll down, we'll see that the prescriptions say other prescriptions here. And this is because I don't have a DEA number. When you first use the system, you need to enter in your DEA numbers. And you see this warning here. You can do that by clicking My DEA Numbers. It takes you to this page. If you have multiple DEA numbers, you can enter them here, click Add, they will be listed, and what that will do is consolidate all prescriptions dispensed under your various DEA numbers. You can also get to this page by clicking My DEA Numbers up here. For those of you that are data wave docs, I will tell you that you cannot enter your DEA X license that allows you to prescribe buprenorphine, but we combine that behind the scenes for you. So if you enter in one of your DEA numbers, we will automatically integrate any prescriptions that were dispensed under your DEA X license that the CFR allows us to present. So going back to patient search, this time I'm going to look up a different individual. This one is Crystal Kringle, she's female. You can also use the cursors to scroll through to the date. So Crystal Kringle, who was born on Christmas in 1945. Is that her? Yes. Continue. You see information here for Crystal Kringle, and you see that she was prescribed clonazepam and tramadol by Dr. John Snow. She was given 1 milligram, 60 tablets, a 30-day supply by Dr. Snow. The prescription was written on June 22nd and was dispensed on June 27th. You can also see that there's a separate entry for Crystal Kringle here. Same date of birth, but now it's a different address. Instead of Baker Street, this is an address for Yellow Brick Road, and a different prescriber as well, and a different drug. Your patients, the information is presented as it was received by the pharmacy. And as much as we can correct inconsistencies and errors, we do that. However, short of going into each and every patient record, and again, we receive about 24 million records a year, we can't verify that the information is absolutely correct. What we encourage you to do if you find an inconsistency is contact the pharmacy. For the Department of Health to correct it, what we have to do is we have to schedule an interview with you. We have to go through your medical record and your prescribing records. We then need to go to the pharmacy and go through their records, dispensing records, and internal system as well. We can't take somebody's word for it. And there is one error that I will tell you that we are seeing reported to us and has been reported more and more often, and it came up at a MSSNY presentation I gave in Suffolk County last week or the week before. Say it's Dr. O'Leary who prescribed, and I now look in the system and I see the prescription is attributed to Dr. O'Malley. It's usually a name very, very similar to the name of the actual prescriber, and the doctor will write us and say, I wrote that, not Dr. O'Malley. The error is the pharmacy has chosen the wrong name out of the drop-down menu, which is, of course, the handwriting error of the 21st century. A doctor spoke up at MSSNY's presentation, my presentation in Suffolk, and she said she had contacted 3 separate pharmacies with different errors, and she said each of them, it was a quick conversation, and in each instance, the error was subsequently corrected and submitted to the Department of Health. That is the most time-saving fashion to do it. We would encourage you to reach out to the pharmacies. And so you know we have made effort among both the Pharmacy Society of New York as well as individual societies and chains to have them be more receptive to these phone calls, more attentive to reporting appropriate and accurate data so that it doesn't affect patient access. So you see at the bottom here, there's an asterisk next to the drug that was dispensed, and that denotes that it's a compound drug. Often testosterone and other drugs are shipped as a compound drug. This will tell you that there was more than one controlled substance dispensed, but it will usually list the predominant or the steroid or other predominant drug which was dispensed. So there's a button here that says Extended. If you click Extended, what it's going to show you is the payment method as well as the dispenser. So you will be able to know what form of payment your patient used, whether it was third-party private insurance, which is what this indicates, whether it was cash, which is what this indicates, Medicaid, and you will also see military or federal or government insurance as well. That's how it's reported to us through the ASAP formats. This is valuable information, particularly for people who are concerned about doctor shopping at diversion and abuse. If you're a pain management specialist who uses a pain agreement or narcotic agreement with your patient, They very often would require that your patient see one prescriber, go to one pharmacy, and use one payment source. This will tell you whether or not they're actually doing that. So under dispenser, these are fake dispenser names. One of the comments we've received is when we present one of the chains, what you'll get is the chain name, say CVS, and then the number of the store, say 1312. If you were to search CVS 1312, Google search, you would get the phone number. What we would like to do down the road with additional programming after we roll out the initial phase is put in a hyperlink so that you could email them directly off of the PMP. You currently cannot do that, but that is anticipated for the future. But this will tell you the specific pharmacy at which the drug was dispensed if you should have a concern. So down here at the bottom, you see to report a prescription discrepancy, please click here. If you click here, what it will bring you to is this screen, and you can see it has my name, it has my office phone number, it has my email address, it has your information as is entered into the HCS. If you were to type into this box what your concern is, the information will come directly into a secure email account within the Bureau of Narcotic Enforcement. You can include patient identifying information. It will not go to anyone who does not have access to it. We do monitor this email account every hour. We may not get back to you immediately, but I can tell you that every single email is read. To help inform us, what you can do is include the reference number off of the search right here so that we can go in and look at the specific search that you referenced. Other things that you can do is you can also make specific into a separate email account if you have other questions, comments, or suggestions. We do take all suggestions, and even though August 27th is when we intend to have this application fully developed by, we have scheduled and budgeted for follow-up programming to address customer feedback. I would just ask that you make it constructive as opposed to a rant. But anyways, so other things you can do up here at the top, you see clonazepam listed here. If you happen to not know what clonazepam was, you could click on drug listing, and it takes you to this. It's a list of every active ingredient drug that is controlled in New York State. To the right of it are the brand names of those drugs. Obviously, hydrocodone having the most brand name drugs. You see for fentanyl, Actiq, Duragesic, fentanyl, Fentora. It tells you what schedule that drug falls within, and remember, the ISTOP requirement applies to Schedule 2, 3s, and 4s. So this will tell you if it's a 2, 3, 4, or 5. And finally, it tells you whether under New York State or not you can write for refills. Is it refillable? So you see here, Potiga is a Schedule 5 and is refillable. So that is under drug listing. Now the next question is designees. How do my designees access the system? They need an HCS account. I cannot stress enough, for your own protection, you do not want to share your HCS password. It's a violation of the terms of agreement. If you have DEA numbers entered, it very well may be a violation of your registration with the DEA to allow others to use your registration number to access patient confidential information. Once they have an HCS account, you can designate people within the system, and I'll show you right now how to do it. You click on designation up here. You go to enter the designee's HCS ID. So I put in an ID, I search for it, and there's Dr. Nurav Shah. I want to designate him. I click designate, and Dr. Shah is now my designee. He is allowed to perform once the capabilities rolled out. And as you see in the drop box here, designees won't be able to do searches until August 27th. It may be shortly before that if the regs are adopted, but as of the 27th is when designees who are not licensed professionals will have access. So Dr. Shah is now my designee. What this means is if you were to go to patient search, and please keep in mind if you ever want to do a new patient search, you just click on patient search and it takes you right back to that page. I'll do another webinar and we'll have up more information, but what a designee will see, above first name will be a drop-down menu. And in that drop-down menu will be the name of every single licensed practitioner who has designated that individual. The proposed regulations place no limit on the number of designees you can have. It places no limit on the number of times an individual can be designated. You can be designated by every practitioner. Even if you're a practitioner, you can be their designee of every practitioner you work with, everyone in your office, as long as they meet the statutory requirements. Basically, they need to be HIPAA compliant and have some type of relationship with you, whether it's working at the same facility, under contract, or under contract with someone with whom you practice. And they have to be within New York State. When a designee does a search, they have to be within the state. You can't outsource designee searches. So what they'll see is a drop-down menu of, it'll be right here, of each and every practitioner who has designated them. And the designee can search who they're searching on behalf of. So again, if they're looking for Jack Spratt, if Dr. Shah had looked up under Jack Spratt, what they would see is search term, search date, and right here where it said this report was requested by, it would say Nirav Shah, and it would say on behalf of Terrence J. O'Leary. And again, if you print this out, this will print out onto a standard 8x10, 8x11 piece of paper. This is a way to keep track of who actually accessed the information, whom they did it on behalf of, so that it protects you, the practitioner, saying, no, someone did the search for me even though I didn't. DOH will have internal logs. There will be an additional tab up here at the top when designees can do searches, and what you'll be able to access is a list of each and every search that you've done, and it will give you this information right here, the search terms and the date of the search, and it will also give you the same information for your designee as well, the searches that they did under your name. So now, say Dr. Shah has been looking up his next-door neighbors under my name, abusing his privilege, and doing so is a violation of the Public Health Law, the Patient Privacy Act, as well as a HIPAA violation and a possibly violative of your DEA registration as well. So it's time for Dr. Shah to no longer be my designee. To remove him, I click the box and click remove, and that's it. So as I said before, you can designate as many people as you want, and if you go through and designate all those people, they'll all show up in a list underneath my name. And if I just want to get rid of a couple of them, I can click multiple ones at a given time. If you're moving practices, if you no longer want to be associated with those individuals, you can undesignate multiple people or just one at a time, and you can redesignate them as quickly as you would like. A couple of other things you can do. If you look up here under FAQ, if you click on that, it will take you to a PDF document. This document is on our website, but you can print it out. It is a 13-page document which goes through some of the most frequently asked questions. We have already altered it in the first month since it's been posted, and we will continue to change it so that it addresses the questions that we get in. Other things you can do, if you click Help, you can, if you're having a problem with the application itself or have other questions, again, you can click this web form and it will submit an email directly to B&E. You can also use that to report suspicious activity related to controlled substances if you have concerns about doctor shopping, diversion, or abuse that need to be reported to the Bureau of Narcotic Enforcement. Doing so is activity that is exempted from HIPAA and required by Article 33 and Part 80 of the New York State regulations. Excuse me. If you have concerns about your patient and you want to steer your patient into treatment, you can call this phone number right here. That is OASAS's Hope Line. If you don't want to call the phone number, you can click on that link. It takes you to OASAS's homepage. And again, right here, you can click to find a provider. It also gives you the list to OASAS's Hope Line so that you can help provide information to a patient who you think needs to seek help. Other things that we have up on the website currently, you see here Search Results Help. If you click on Search Results Help, you get this document, and it says how to read a confidential drug utilization report. It tells you where the information comes from, where to find search terms, what the description means, the report reference number. It gives you information on what is presented within the report. If you click on Update Personal Info, I'm not going to show you my contact info, but I will show you this. That fax number is not correct, so don't send me any faxes there. That phone number does work, though. If you want to call in, you can call B&E at this phone number. Something that we're going to allow you to do by the end of this year is under Update Personal Info, you can go in and view your physician profile. Those of you know who are physicians that you have to re-register every 2 years, and you have to attest that the information that DOH has for you is accurate. You'll be able to verify that the information is accurate, and you can change it just by clicking through and altering the information as is appropriate. So again, we're trying to incorporate as many functions into the PMP as is possible to try and encourage use. Trying to think what else there is here that I haven't covered. I think that's about it as of right now. So if I go back to Shakira, I'll give you this information back. So that's a quick overview of how the PMP works. We are proud. We do think we've made something that is user-friendly, much more so than was in the past. Come August 27th, what you'll be able to do is you'll be able to do up to 30 specific patient searches at a single time. You won't have to keep going back to the patient search button. And what will happen is they'll be in list form, and it will tell you that you have results for patients 1 through 20 and no results for 21 through 30. You can then print out all of those reports at a given time. You can view them all on the screen at a given time. If you choose to print them out, there will be page breaks so that no two patients' information prints out onto the same document. And by October or November of this year, what you'll be able to do is download each report as a PDF file, and all EMRs are required by the Office of the National Coordinator to be able to import and display PDF files. Something the department's actively working on now is integrating EMRs with the PMP, and eventually what we're going to do over the course of the next year and a half is do additional programming and leveraging technology through the SHINY and the various regional health information organizations, enter into business agreements so that vendors can ping the PMP through your EMR so that they'll automatically request all of your patient's information. There will be no actual search. That's not going to be available come August. That won't be available by the end of 2013. However, we are actively working on that, and it's something that we hope to roll out within the next year and a half. So future PMP registry functions. We are currently in development for Phase 3. I have been, and others within the department, have been doing bulk patient searches, doing tests and looking up 30 individuals at a given time. It's working well. We have a couple of quirks to work out, but we hope to have that rolled out within the next couple of weeks. You're also going to be able to look up practitioner reports. You will be able to see almost like a bank statement of everything that's been dispensed under your prescription history if you enter in your DEA numbers. And again, if you combine your DEA numbers, if you have multiple, you'll be able to search all of them at a single time. As I said before, for pharmacies, they went from monthly reporting to daily reporting. We've already worked with them on cleaning up critical errors, and we've been improving the quality of the data submitted over the course of the last 8 months, and we've had a great deal of success in terms of the number of files that had errors and needed to be returned. We're going to allow them to report and automatically through an unintended secure reporting solution. We're also going to allow them to correct their errors online. Believe it or not, the system we currently use is we fax all of the errors, a list of the errors to the pharmacies, and work with them over the phone. It's a very outdated system, and we're using this law to improve the efforts in improving the PMP to make it easier for pharmacists to use as well. So if you go to the next slide, this one just talks about e-prescribing. and there will be a great deal of outreach following up on this after ISTOP implementation. E-prescribing was first allowed by the DEA in March of 2010. A number of states automatically adopted federal regulations. New York did not. In March 27th of this year, we finally adopted regulations that allow for the e-prescribing of controlled substances. Our regulations are published. They're available online. They're also available on B&E's webpage in the state register, and I believe MSSNY has made them available as well so that you can review them. In terms of security, we do not require anything more than what the DEA required. What we do ask and what the regulation requires is that you report to us which DEA-compliant application you are using. And MSSNY has a great deal of information on their website about the various e-prescribing applications that are available to you. The Department of Health does not endorse any one. We certainly are in favor of increased research and development so that there are more applications and that they're more affordable, and we do think that the marketplace is becoming more and more active as the March 27, 2015 deadline rolls in, which with limited exceptions, as of that date, electronic prescribing of both controlled and non-controlled will be mandatory. So this is my contact information. That website will have a great deal of information on what B&E is doing, not only regarding ISTOP and e-prescribing, but we were also in charge of the governor's efforts to combat synthetic cannabinoid and bath salt abuse. We are the bureau that sends out official prescriptions. So we sent out 147 million forms last year. If you have issues with official prescription forms, you can contact us. If they are stolen, please contact us. We are the only law enforcement agency when New York State official prescriptions are stolen who report it to Medicaid and to other pharmacies and interested stakeholders as well to keep them from paying and dispensing on stolen prescription forms. We do have regional offices. Albany is out of the central office. New York City, Buffalo, Syracuse, and Rochester all have narcotic investigators who can help you with any concerns you may have about investigations of diversion or abuse. We also have 6 pharmacy consultants, licensed pharmacists on staff who can also help answer questions that you may have related to controlled substances. So with that said.
Thank you, Terry. Before we move to our questions, and we're going to do it 2 ways. We're going to do it via chat, and if you see the chat area, you can send us a chat. We are also going to allow verbal questions, and you would need to raise your hand, and we're going to have Shakira show you how to do that on the computer, and we will take just by raising a hand, you can see it under our name. We will take those questions in order. I will say that there are several who have logged on just by phone. I do need confirmation from you by email that you attended the seminars, because not connecting with the computer, I'm unable to see your name. So please email me at pclancy, C-L-A-N-C-Y, @msny.org with your name that you attended the session tonight, and we will make sure that you get your CME certificate. We will have an evaluation, but right now we are actually going to do one of the chat questions, and then we'll alternate between the chat and the question. And Terry, I'm going to let you read the questions.
So the first question is, do we need to save documentation of having searched the patient's file in our office, or is the tracking that the system does good enough? So the proposed regulations current regulations and law require that you keep a record whenever you prescribe a controlled substance, and that's usually done in the medical chart, the medical record. The proposed regulations would require that you just indicate whether or not you checked the PMP. So yes, I checked, no, I did not. It does not say that you have to print out the record. It does not say that you need to view the record in any specific fashion. So just viewing it online would be good enough, as long as you wrote in your record that I checked the PMP, no more, no less. And as I said, if you needed to go back and somehow access that record, you will be able to audit your own search history. The Department of Health also has access to that record. However, what we can't do is give it to you outside of the PMP because it is subject to, it does contain patient identifying information, so we can only disseminate it in a specific fashion, and that's through the audit function within the PMP.
Okay, we're going to actually unmute Dr. Jeffrey Long. Dr. Long, if you can ask your question.
Yes.
Go ahead,
I don't
please.
have a question. Sorry, I must have pushed the wrong button.
We'll go to question 2.
So the next question is, will both controlled and non-controlled substances be entered electronically the same way? When e-prescribing becomes mandatory, you will have to e-prescribe both controlled and non-controlled substances. The security standards are very different, though, and I don't want to speak too much about that, but for everyone who is e-prescribing now, if you don't know if your application is compliant with the DEA and ONC's requirements, it most likely is not. If you never prescribe controlled substances, you will not be required to buy a EPCS, Electronic Prescription of Controlled Substance application. There will be no need for it. The security standards will be the same as it is for non-controlled now. So that question in part depends upon your practice, depends upon the application that you choose to use. I'm not sure if you're talking about the original ISTOP proposed by the AG back in June 2011. That would have required that practitioners upload information into a database to then be transmitted to the pharmacy separate and apart from actually prescribing. There's no requirement, in part due to the advocacy of MSSNY and I'll say also the Department of Health. We got away from that. That was a system we didn't think served the purpose that we were trying to address. So if you're thinking about the original ISTOP where practitioners had to upload information, that is not part of the law. There's no requirement. When we go to e-prescribing, it depends upon what you're prescribing, whether or not you need to use, what application you're using. Again, the marketplace for applications is growing. I don't want to tell anybody to wait if they're ready to prescribe controlled, but I think you'll see many more choices a year from now in the summer of 2014 than you see right now. So that's something to consider when deciding when to make the investment in an e-prescribing of controlled substance application. Okay,
Dr. Abraham Nussbaum, you're unmuted. Can you ask your question?
Yes, thank you. I want a little bit more detail, please, on this electronic prescribing. We've been doing electronic prescribing since December of non-controlled substances, and at the time that we started, I was told that controlled substances were not yet permitted in the electronic system. You're saying that they are now permitted in the electronic system, but that the vendor has to have a specifically compliant program? Is that what I'm understanding?
Yeah, so at the time, in December of 2012, e-prescribing of controlled substances was not allowed in New York State. There needed to be enabling regulations. They were adopted on March 27th of 2013. So now if you have a DEA-compliant application, you can e-prescribe controlled substances. However, if you don't know whether or not your application is compliant with the DEA, I would bet that it is not compliant with the DEA. The DEA requires two-factor authentication for the transmission of any e-prescription for controlled substance, which is usually a token and a password. You have to undergo identity proofing through the DEA. You have to show the DEA that you're a DEA licensed or DEA registered prescriber. It's my understanding that many of the vendors that offer these applications do the identity proofing for you, but not all e-prescribing applications, and in fact very few current e-prescribing applications are compliant with the DEA, and therefore all DEA e-prescribing of controlled applications encrypt and transmit the prescriptions using public key infrastructure, PKI. Most e-prescribing applications do not use PKI yet, but it needs to be compliant with the DEA. You would know that, and your vendor would have told you that up front. Some vendors can upgrade your system, and they have received DEA certification. Not all can, but that's a discussion you need to have with your vendor. Okay. So the next question is, I know the law does not apply to inpatients, but what about prescriptions for patients upon discharge from the hospital? There are a number of exceptions. If you go to the B&E update, which is on both MSSNY's page and B&E's page, it will tell you what the specific exceptions are. The one that this question is asking about is if you're prescribing a controlled substance for use within an institutional dispenser, you do not have to check the PMP. So if the entire amount of controlled substance medication is going to be used in the hospital or the nursing home, that is an exception. You don't have to check. If the patient is going to be discharged with a portion or all of those tablets, or if it's a nursing home and the patient is going to be going on a therapeutic leave with the drugs, you will have to check. So discharge is not accepted or exempted.
Okay, we're going to Dr. Ellen Buckbinder.
Yes, hi.
What's your question?
I want to know, I have applied for my own HCS account, but how do I apply for a designee?
Your designee needs to apply for their own account. If you go to MSSNY's page or the B&E page that we put up, there will be two PDFs. One will say getting an HCS account for a licensed professional. One will say getting an HCS for an unlicensed professional. So depending on whether the designees that you want have a state ed license for some type of profession within New York State that allows them to prescribe, or whether they don't, you'll have to choose one of those two. They have step-by-step instructions, including screen grabs of the website and how to do it.
Okay, thank you.
So the next question is, what are the penalties associated with noncompliance with the duty to consult after August 27th? The specific penalties that were in the original bill were removed. Those were monetary penalties only, $500 for the first time you didn't consult, $1,000 for the second, and up to $5,000, I think, for each and every subsequent violation. Those were removed in large part because we do want to encourage people to use this as opposed to get them out of the business of prescribing and treating patients. However, that being said, the same sections of law that apply to other public health violations apply to ISTOP, sections 12 and 12B. And in the most egregious instances, a 12B violation where it is willful misconduct, where you are intentionally not compliant with the law and where you do not have an exception to avail yourself of. The maximum penalty is a $2,000 fine, 1 year in prison, and the permanent revocation of your license to practice.
Okay, question number 4.
So the next question is
yeah,
oh, I'm
want
sorry.
to ask, well, actually, that's a quick one. You can answer that
Next
one.
question is, will each new script has to be logged into the system at the time of dispensation?
Yeah.
So when the pharmacies are required, anytime a pharmacist or a practitioner dispenses a controlled substance, they will have to report into the HCS within 24 hours. The format for reporting will either be through UPHN Lite, which is the Department of Health's unattended reporting solution that we currently use for the reporting of Sparks data, NIPORTS data, and other information, or you can upload the information each day if you choose in batch format, similar to the way that many pharmacies report to us now.
But the physician does not have to enter the data into the...
Well, if the physician is dispensing,
Yes.
They have to report to us, and that comes up most often in
Clinic settings.
sleep clinics and weight loss clinics. However, if the physician is merely writing a prescription, they do not have to upload any information into the PMP. What they need to do is consider the information presented in the PMP before they make a decision whether or not to prescribe a controlled substance.
Okay, and Dr. Amali Shulin, your question, please. Dr.
Yes,
Shulin?
yes.
Yes, go ahead.
I had a question, first of all, about hospice patients and hospice prescribing. Do they have to report each and every narcotic being used on hospice patients?
So if information is reported to us regardless of the treatment setting for the patient. So a pharmacy that dispenses controlled substances to a patient, that is reported to us. It doesn't matter if the patient has been admitted to hospice or not. A practitioner who is treating a patient that has been admitted to a hospice program, as defined in Section 4002 of the Public Health Law, you will not have to check the PMP before prescribing to that patient. But then again, it's not palliative. It's not an exception for palliative care. It's an exception for hospice, as defined within 4002 of the Public Health Law. But that being said, if you write a prescription to a patient who is admitted to hospice, you will not have to check before that you prescribe to that patient. But when that medication is dispensed, that record will be reported into the PMP. So if you look, that patient's information should be there. And one thing I will say is that the utility of the PMP goes beyond thwarting doctor shopping, diversion, and abuse. We've received numerous calls from practitioners who have found out that their patient is seeing another doctor. And the example that comes up most often is a primary care physician treating chronic pain, and the patient is also seeing a psychiatrist and receiving a separate benzodiazepine from the psychiatrist. So you can check. It may tell you something about what the other members of that team treating the hospice patient are actually prescribing that you wouldn't have known short of speaking to them directly, but you do not have to beforehand. So the next question is, what are your recommendations regarding residents in an ambulatory health center? Residents being people living there, or residents practicing?
I'm assuming it's residents practicing in the ambulatory health center.
So residents, under the law, residents are not considered practitioners and are not given direct access to the prescription monitoring program. However, residents can be designated by the attending or by the preceptor. Something to keep in mind is ISTOP in no way changes anybody's scope of practice. If you could prescribe before, you can prescribe now. If the resident was able to prescribe under an institutional DEA with a suffix attached to it, they can do so now. There's no requirement in the law that a resident, upon viewing a controlled substance history in the PMP, present that to the attending or to the preceptor or any type of supervising physician. Of course, they may see something that would cause them to consult with a supervisor, just like something that may come up in an examination would have them do the same. But something that's very important to keep in mind, ISTOP in no way changes anybody's scope of practice. Residents, however, will have to access, if they want to look it up themselves, they will have to do it as designees. One thing I'll say is this system currently works not only on a laptop, it works on my Droid, it works on my BlackBerry, it works on iPhones and iPads. If you are having an issue, what I will say is one thing we found with the iPhone 5 is that you have to enable pop-ups. If you have pop-ups disabled, you will not be able to see the PMP. One other issue is we found with Droids, if you use the Dolphin web browser, it works, but it's not great. We suggest that you use Google Chrome, you use Firefox, or you use Internet Explorer versions 8 or 9.
This question is all together. I mean, it's basically the.
So there's a comment that life would be easier if you could search a Monday morning patient on a Friday afternoon. That was actively considered by the ISTOP work group, which was comprised of practitioners, pharmacists, consumer advocates, and law enforcement agents. And we all agreed life would be easier, but we also thought that a lot of diversion and abuse happens over the weekend. So that exception was not allowed for. It's 24 hours regardless. We also didn't tie it to a business day because business days vary from practice to practice and pharmacy to pharmacy. I will say the 24-hour reporting window for pharmacies as well does not account for days off either. With that being said, under the current system, we are most busy Monday mornings between 10 and 11 a.m., and we get about 4 or 5 individual searches each and every second during those 2 hours. The next most busy time is Wednesday, midday, then Tuesdays, then Thursdays, Fridays, Saturdays, Sunday in order. We realize that Monday morning is going to be an issue. We think the bulk search feature, which will allow you to look up 30 patients at a given time, will help accommodate that issue. We also think that you can have administrative staff do the search for you, should also ease the imposition on your workflow.
And then Dr. Gary Bissett, your question, please. Dr. Bissett?
Yes, I'm just clarifying that my understanding from what you said before was that patients that are discharged from the hospital or from an ambulatory surgery center, that there is no exception to checking the PMP, that we have to check those before these patients are discharged with a prescription. Is that correct?
That is correct. You can access the system up to 24 hours before you prescribe. So if you have scheduled procedures the night before or the morning of, you can access all of their histories and have it ready for you so that you don't have to stop in between procedures. If you have an idea of who is going to be discharged, you can have it printed out the night before or the morning of, but it is not an exception to checking the PMP.
Okay, and actually that kind of ties into the next question, Terry.
So from Ellis Medicine, Jennifer Alex, it says, for patients being discharged from the inpatient hospital stay, can the 5-day rule apply, or do we need to access the site 24 hours before ordering prescriptions? Again, the 5-day rule does not apply. You do need to access the site no more than 24 hours beforehand.
Okay, Dr. Francis Miles, I believe your question.
Yeah, hopefully something simple. If you've mailed out your notarized form to establish the account, how do you receive confirmation that everything's been approved?
You should, well, if there's an email attached, you should receive an email, and you'll separately receive your HCS password. You know, Dr. Mel, I think that's, yeah, you know what? If you can send us an email, and I'll follow up on yours individually. Congratulations, you got me. I'm pretty sure it gets mailed and an email if an email address was provided, but I am not 100% certain. So I'd like to follow up. So feel free to contact B&E. I'll find out that information. I'll also pass it along to Pat so that they can post it. That's a good question.
Yeah.
Thank you.
Next question. Who can be a designee?
Okay, who can be a designee? Does it have to be a doctor, or could a medical assistant in the same office be one? So the regulations are currently proposed, and to summarize, and I can't comment too much because they are out for public comment at this point, what it anticipates is that it is someone who you employ, someone who is employed by the same practice, someone who works at an institution where you have privileges or otherwise happen to treat a patient. So a patient of yours is admitted to an institution at which you treat the patient. One of their employees can look the person up. It also anticipates that the designee is trained in relevant federal and state privacy laws, which, you know, in common parlance is HIPAA compliant. Has the person been trained on HIPAA? And that would be, I would hope, anyone who has access currently to your medical records. There's no requirement that they have any type of license. It does not have to be a doctor, does not have to be a physician's assistant, an RN, or a pharmacist. It could be a front office staff. There's no licensure requirement. As long as, one, they do the search within the state of New York, two, they are trained in privacy and state statutes, and there's some type of employment relationship as the reg says. But that's it. Beyond that, it can be anybody else.
Okay, and then we're going to unmute Dr. Amit Singh. Dr. Singh?
Yes, thank you for taking my question. I've been looking at the website. I've been trying to use it frequently. One of the things that I find that it takes some time to go between my electronic medical record, finding the date of birth and putting it in. Now, since I write the same prescription for the same patient every month, is there a way of saving them in an alphabetical list somewhere, and I can just say update search and look at the latest search for that day, or do I have to re-enter the patient every time?
Currently, you have to re-enter the patient each time. You need to put in the search terms each and every time. One of the things, as I was talking about before, is trying to integrate with EMRs, and we're taking ultimately, and other states are ahead of us on this actually, it'll automatically be integrated. So your secure EMR will ping the PMP, and looking at the patient's name, date of birth and gender will automatically pull that information for you. But until we get to that point, you will have to go back in and do a search each time you decide to prescribe to that patient.
Yeah, and okay. Terry, I actually believe that probably the biggest question that I get here at the Medical Society is about the 5-day rule. So if you could explain when physicians and prescribers can issue a 5-day script and what the conditions are for that authority to kick in.
So again, I'll steer everybody to the B&E update, which will you can find on MSSNY's webpage or mine, which will talk about what the 10 enumerated exceptions are. One of those exceptions are mandatory, and it's actually a preclusion. Veterinarians are not allowed to check. So there are two. One is if you are prescribing 5 days or less, and the prescription is being written within the emergency department attached to a general hospital. So if you're in the ER, you can write up to a 5-day supply.
But if you write a 6-day supply,
they will have to check.
Thank you.
Whether you are in the ER or not, you will have to check. One thing I will say is if you are in the ER, you are a target for doctor shoppers. It is a source of diversion and abuse. It is an exception within the law. It is not my favorite exception. And I have been advocating to some of the associations that represent institutions to try and incorporate these searches into their workflow when patients come into the ER, to have this document incorporated with medical records when they're either created or retrieved. There is a second 5-day supply exception, and that one is more of a catch-all that says if there is something about the practitioner's circumstances where they cannot access the system or have someone access the system on their behalf, and accessing the system, taking the time to access, will in some way adversely impact the patient's medical condition, you can prescribe up to a 5-day supply. This is not attached to any specific patient setting. It doesn't have to be in an institution. It doesn't have to be on the golf course. It's just there's something about your circumstances that preclude you from checking, and having either calling someone to check or going and checking yourself would delay and adversely impact the patient's medical condition. You can do the equivalent of an oral emergency prescription or write it out and prescribe up to 5 days. The proposed regulations are going to require that you enter into the medical record what the barrier to checking was, and two, how it would affect the patient's medical condition. So keeping in mind that there are a number of ways that you can check the system through smartphones, through the internet, and that you can have individuals check for you. that you don't have to be the one sitting at the computer. Someone else who is sitting at a computer or does have a smartphone could check for you. Keeping that in mind, that is an exception. I can't give you a specific example, such as, the 13th green doesn't get reception, but the 18th does, and that delay would have affected my patient. I can't say that that's appropriate. I think time and experience will bear out what is appropriate. Just know that you are required to document those circumstances, and you may be asked to justify it down the road. So those are the two 5-day exceptions. One is attached to the ED, and it's the ED alone, and if you happen to practice at one of the state's now 2 standalone emergency departments, you cannot avail yourself of this exception. You have to be attached to a general hospital, and that means physically, not associated with. And the other one is based upon your situation and adversely affecting the patient's medical condition.
Okay, thank you, Terry. Ellen Guerin, we have unmuted you. Dr. Guerin?
Hi. I just was wondering about who can actually, can nurses send electronic prescription renewals of non-controlled substances? It's a question I get a lot.
Nurses don't have prescribing.
Not if it's.
If they're a nurse, they don't have prescribing ability. They can.
If they're a nurse practitioner.
If they're a nurse practitioner,
then they can. But if prescribing is not within their scope of practice, they can't send renewals either. So it would depend on what type of nurse they are. But it would be limited to nurse practitioners.
Thank you. That answers my question.
Okay.
Is there a legal form for my designee to sign that I need to have in their permanent file? I think that's a better question for your counsel. If you want to document that they've been trained and that they understand, because the law does envision, while there's no technical limit on the number of designees you can have, the law does say that you are responsible for the searches done by your designees. Something to keep in mind is that if there's an instance where your designee looks up A-Rod or Derek Jeter and you immediately undesignate them as soon as you find that and take appropriate action, while you are technically strictly liable for that search, I don't think anyone would believe that had you met the requirements that would be an appropriate area for enforcement. In fact, you're ahead of the game as far as I would be concerned. So whether or not there's no legal requirement that you put something in the permanent file, the regulation and the law don't say that, but whether or not you want to document the understanding is something completely separate.
Okay, and we're going to go to Joel Greenberg. Mr. Greenberg? Mr. Greenberg? We're going to mute you.
We hear you typing.
Right, well, actually, right there, what are the penalties associated with noncompliance with duty to consult after August 27th?
So, again, it's a Section 12 or 12B violation, willful misconduct being punished, being an unclassified misdemeanor punishable by a $2,000 fine up to 1 year in jail, and the possible permanent revocation of your license. The unlawful dissemination of this information, if you were to give it to someone outside of the scope of your practice, and as is appropriate, is also a violation of the public health law. It is also a violation of HIPAA, a violation of the Patient Privacy Act, and possibly of your DEA registration.
Yes. And right now what we're going to do is we are going to launch our poll and our survey, and it'll plug along for the next 15 minutes, so please fill out the evaluation. But we will keep on with our questions, and we will go to the next question, if you check.
If you check your professional data on the site every 2 years, does that mean you already have an HPN account? So if you're getting onto the HCS, the HCS is the HPN. It's the same, the two acronyms refer to the same system. So if you can get onto the HCS, you have an HPN account. Currently, you can't use the PMP, which resides on the HCS, to update your physician profile. That's not yet available. That will be available by the end of this year, though. What I showed you, my information, if I were to update that, that only updated my HCS or my HPN account. It does not, and you'll see something similar. Currently, that will not update your physician profile, but we are working to incorporate that.
And Richard Hahn, we've unmuted you.
Hello?
Hi, Richard.
Hi.
Go ahead. Your question?
Yes, my question relates to a New York State prescription being filled in Connecticut or New Jersey by a patient out of state. How is that going to affect the requirements to search the database?
It doesn't change the duty to search the database, although obviously this is a New York State system and we do not have access to prescriptions filled in New Jersey or Connecticut, with the exception of prescriptions that were filled at a chain. So many of the chains will report official New York State prescriptions to us regardless of what state they were filled in. To get that information from other PMPs, we have to be interoperable. That's the term of art. There's no contiguous state to New York that is ready to be interoperable with us. If you write a prescription to a patient, the patient gets that prescription filled in Connecticut or New Jersey, there's a very good chance that it will not present in the PMP. That it would have been dispensed, they received the drugs, but it doesn't show up in the PMP. However, the law that applies depends upon where the act is taking place. So for the person prescribing, it depends on what state you're in. And if you are located in New York State, regardless of where it's being filled, you have to check the PMP unless it's appropriately exempted. The reverse is true as well. Doctors writing in Connecticut for a prescription that will be filled in New York State do not have to check the PMP. We can't tell them what to do. What we see a lot of over the last couple of months, though, is we will get prescriptions coming into New York State for hydrocodone with 5 refills. And the pharmacy in New York State cannot honor those refills. And once it's actually filled in New York State, you can't transfer a prescription for a controlled substance. It requires a new prescription from the out-of-state prescriber. So whether or not the law applies depends on where you are when you prescribe, and whether or not the law applies to dispensing depends upon where the pharmacist is, where they prescribe. And it very often could be that 2 separate states have applicable laws. So the next question is, Dr. Singh asked this question.
All right, okay. Let's go to the next one.
For patients who come in for monthly narcotic prescriptions, before I can prescribe the medication each and every time, will I have to check the PMP? Yes, you will. And one thing I will say is we have received numerous comments as to, from individuals saying, now I understand why I need to check each and every time. I would encourage people to use the system. I've found that the 2 hardest things about this are, 1, getting your HCS account. You have to start that process and get your HCS account. And 2 is the anxiety. People just anxious about what this system requires of them and how are they going to use it. We have received very few bona fide complaints from people who have actually used the system. And in fact, one of the things that I wanted to do was when we rolled out the new system, and I'll say, we rolled it out 2 months ahead of time and we're under budget, ahead of schedule and under budget. I wanted to have prescribers who had said I would never do this, but then had a road to Damascus moment and now enjoy using it, to have someone write an article that we could put in the B&E update. And we've in fact had so many individuals who have said that, I've seen the error of my ways, so to speak, that we've turned it into a mini essay contest, because we are finding that practitioners like using the system when they figure out how to incorporate it into their workflow, and that doing so, incorporating it into their workflow, is much less onerous than what they originally feared.
Okay, and the next question, how will compliance with this program be monitored?
So, well, let me say that we built this system knowing that we would have to monitor it. Obviously, there are very obvious ways we can monitor who logs in, who does searches. That can be checked against actual dispensed prescriptions. Beyond that, I just draw the analogy to when you go on vacation, you don't call the state police and say where your speed trap's going to be. We're not telling everybody how we're going to be able to catch those who are not doing this. Just know that it's the intent of the department to get people to use this system, not to catch them when they don't. We don't want to drive people out of prescribing. I do think a lot of you who may or may not be using the system will be receiving notifications very early on. Those notifications will be followed by a knock on the door, and the knock on the door may then be followed by a notice of some legal action if you persist and aren't doing this appropriate. There will be enforcement. It's not going to be heavy-handed in my estimation. We want to encourage people to use this. It is an evidence-based decision. If you look at the literature regarding the efficacy of prescription monitoring programs, you will see that it corrects prescriber behavior. It doesn't always lower the amount of drugs or whether or not someone prescribes. There are studies out there that show that in up to 20% of the instances where PMPs are consulted, it actually increases morphine equivalent doses prescribed to a patient, that it somehow tells the practitioner you're under-treating this patient's pain. So this is about informing your clinical judgment, not replacing it. And we really do want to encourage use not to put up barriers to patient access.
Before we move on, we have a question as to where the evaluation is for the CME. It is online. It's available. It's been posted. For those of you who are attending at Ellis Hospital or at Erie County, I believe that there is a written evaluation that you'll be asked to fill out. We are going to go to the next individual, and I believe it's Dr. Tan? Hi. Your question. I'm sorry?
That's your voice. It's the feedback.
Oh, all right. Okay.
Maybe I'll jump to the other questions.
Yeah.
One was, where can I find a list of Schedule 2, 3, and 4 medications? If you go to the PMP, you will see the list of all controlled substances and the schedule, all Schedule 2, 3, 4, and 5s. Obviously, we don't list Schedule 1s. If you're prescribing them, please stop. But for the 2, 3, 4s, and 5s, you'll see the list within the PMP. I spoke with Pat. We used to have the list up. I thought it was much more prominent. Pat indicated that it wasn't, so I will go back to our website and check. We've completely overhauled our website over the last 3 months. It was exactly the same for about 4 years, and we've focused on updating information. I'll make sure that that didn't get lost in all of the updating.
Yeah. So, and then we're going to Michelle Montemaya, I believe. Dr. Mayer, Montemaya.
Yes, Dr. Montemayor. Thanks so much for giving us this opportunity to learn. I feel like I've learned a lot. My question has to do with actually my prescribing. Is there any way at this point that we can limit the filling of our prescriptions to New York State if we're prescribing a controlled substance?
This question's come up before, and this would actually fall under state ed law and the State Board of Pharmacy. More than the Bureau of Narcotic Enforcement. The short answer is, and this is an uninformed legal opinion, I'm not sure that you can, and I would warn against. There are anti-steering portions of 6810 of the state ed law which governs prescribing, and it says that the prescriber is not to influence a patient's decision on where to fill the prescription. Obviously, it's not a hard and fast rule, and it was aimed at trying to get around a prescriber steering someone to a particular pharmacy as opposed to not going out of state. One thing I'll caution is that there are a lot of patients, legitimate patients, who do travel out of state. As a former resident of New Jersey who received I had a surgery at Hospital for Special Surgery in New York, and I lived in Jersey at the time. I couldn't get my prescription filled in New York because I had a New Jersey ID, even though I was trying to get it filled at the pharmacy directly across the street from the hospital. So while I understand the intent of trying to keep prescriptions within the state and to keep them on our radar, I would caution that there are a number of scenarios. We just had this discussion internally. There are a number of scenarios where it could limit access for legitimate patients. There are a number of different reasons why people may go out of state other than trying to fall off of our radar. And one thing I'll say is we're one of 2 states that use the serialized official prescription forms. It's us and Texas. And our numbers are unique. We don't repeat. New Jersey just allowed institutions and prescribers to create their own serial numbers. Since we have individually serialized data, what we find is that we get calls from out-of-state pharmacies a lot. And in fact, there was a doctor recently arrested in New York City who was telling patients to go out of New York State, but because New Jersey and Pennsylvania and Connecticut and pharmacists and law enforcement agencies know to contact us, they do so. So that, I would hope, would alleviate some of your concerns. Out-of-state prescriptions are a blind spot, but there are anti-steering statutes limiting where prescribers can tell patients to go, and there are also other concerns for patient access as well. But my opinion is not the official opinion of DOH. It's more of a state ed question.
I guess I'm worried about my attitude becoming one of really thinking if I check this thing that the patient is not engaging in behaviors such as some of the patients we see now doctor shopping. So I'm wondering, would there be any other warning signs one might have, or any way we could consider whether or not this is still going on in a fashion like going across state lines?
So if you're prescribing to a patient and the prescriptions aren't being filled, you can always ask the patient where they're having them filled, and you can contact those pharmacies if in fact they're going out of state. There are other red flags as well for when someone's engaged in doctor shopping and abuse. They're showing up 7 days early. You know, the only people who know the 7-day rules are people tied to reimbursement and doctor shoppers. They'll show up 7 days early. If you have concerns about a specific patient, you can contact B&E. This is what our investigators do. We have 20 of them throughout the state. We have ties to law enforcement agencies out of state. And I can tell you that we actually we're going through New Jersey's PMP today. They were accessing information on our behalf to see if an investigation was warranted in New Jersey. So we have very strong partnership. At a certain point, I realize it's you as the prescriber taking your hands off the wheel and trusting DOH to handle it appropriately, but this is what we do. We are gearing towards being interoperable with other PMPs, which would give you access to New Jersey or Pennsylvania or Connecticut's prescription monitoring program, but we're not there yet. That's a year or so down the road.
Yeah, and we're going to go to David Smith. David, you're unmuted, David.
Okay, thank you. We have a question from one of the doctors in the group, Dr. Kukin.
Yes. Do you track the VA scripts that are filled? I have a number of patients going to the VA.
So VAs technically are not within New York State. It depends on who's filling them. If you are writing from the VA but your patient is going to a pharmacy off of the VA site, that will be reported to us. If it's being dispensed by the VA pharmacy, it currently will not be reported to us. The President, a couple of months ago, issued an a year ago, issued an executive order allowing VAs to report into state PMPs, and there are regulations which will govern their reporting into the PMP. We are actively awaiting getting that data and incorporating it into the PMP, but currently, if it is dispensed on a VA or other type of federal installation or a federalized Native American reservation, we will not get that information reported to us unless they choose to report it. And I will say that most don't.
All right, and then the next question is actually, what is the approximate time for response from the Commissioner regarding approval denial of a waiver from the duty to consult, exception 10 in the regulations?
So there actually is no process currently for a waiver from the duty to consult. It is being proposed. It is in regulation. There is no actual waiver process at this time, so I can't give you a time frame. For those who want to apply, we say that you should probably look at the proposed regulations to inform yourself of what that application would look like, namely a sworn document which would detail the reasons for granting a waiver. However, there is also a duty to be forthcoming on the person applying and to detail circumstances which would tend to weigh against granting a waiver. And frankly, the one people have written in, and what we see is, I don't have internet access. If it's a choice, you're probably not going to get a waiver. If you have access to the internet but have chosen not to access, you will not be given a waiver. You will somehow either have to have a designee access. If you do not have access to broadband technology, if it's beyond your capability, that's something different. The waiver exceptions are for technological limitations or exceptional circumstances not within the practitioner's control. That's very, very important. It has to be one of those two things not within the practitioner's control. So if it's a choice the practitioner is making, then it's not, a waiver would not be allowed.
Go back up. Actually, again, this is the question. If you're discharging a patient from a hospital with a 5-day supply or less, do you have to access the website?
Yes.
I told you I got a lot of questions on this one. Does an exempt provider have to document that they are exempt in the record if they write a 5-day supply or less? I'm not sure what that really means. An ED provider?
So I think it's not that the provider is exempt and has been given a waiver. I think she's saying if you're using one of the exemptions. So if you're prescribing within the ED and it's 3 days, do I have to write in the chart that this was?
Right.
So what the law requires is that the proposed regs is that you document either that you checked or you did not check, and it says that if you use one of the catch-alls, which is the patient safety catch-all or your circumstances and the 5-day exception, that you have to document the circumstances within the medical record. That's what the regulations require. They're publicly available. I would suggest you review them. However, if you are prescribing within the ED, I don't know why you wouldn't write that into the medical record, because if someone were to knock on your door, and again, this will be enforced by people other than B&E, the AG's office, local prosecutors' offices, all have jurisdiction of willful misconduct under the public health law. You probably want that in your record, so a year later you remember why you didn't check.
Okay, and then could you scroll down, back up? Do I need to see a patient every time he requests a renewal of a controlled substance?
The answer is yes. The next question says, the mobile site is hard to use. Will you be developing an app? Go to the desktop website. Don't use the mobile one. It's much easier to use.
Okay. Okay, so
sorry about that.
We had a little bit of technical difficulty here. We are actually at the end of our session. We have some time frames. Our WebEx session is actually going to end at 7:40. We have tried to answer as many questions as we possibly could tonight. If you have any burning questions that you feel have not been asked, please forward them to me at pclancy@msny.org, and I'm on the screen right there. I want to thank Terry O'Leary very much for his attendance tonight. Our next webinar will be on August 7th from 8 to 9:30 a.m. And if you know of colleagues that have not been able to get on, I will tell you that we are planning one additional one before August 27th. That information will be forthcoming. Again, Terry, thank you so much for attending. The poll, the evaluation has also been completed, and if you have not finished or have not had an opportunity, please let me know, and we will email to you the evaluation. And like I said, your CME certificates will be emailed to you via the email. Thank you very much. Thank you, Terry.
Thank you.
Yeah.